Testing, testing. Pardon me. My mic on? 5, test. Testing, testing, testing. Testing. Hello. Test. Hello, everyone. Welcome to EmpowerU Studio. We're so glad to have you back. Yay. Let's have a little round of applause. We're live. Welcome to a lot of people online tonight. It's good to see you again. And over the years, I've done a lot of programs with our speaker tonight, Mike Wilson, and I've seen him do a lot. But I never knew that the presentation tonight could be so powerful that he could get Amy Acton fired. Let's give it up for Mike Wilson. I think that's quite an accomplishment. Not fired, she I think resigned today under pressure. But so that's some news you can use. And everybody has their own feelings about Amy. I know my wife was telling me on the way over, now don't say anything bad about Amy. And I said, I won't, please. But it's great to see you. You know, it's when we got shut down on March 17th, we had so many great classes planned for you. And I'm just sorry we couldn't have presented some of them. So just a few things before we get started. I wanted to introduce you to our team. Betty's back there, Betty Overstreet. Let's give her a round of applause. Jill Google, our operations manager, she may be watching tonight. Let's give her a round of applause. Bill Roll, our chief treasurer, and give Bill a round of applause. And Bill is, I think one of Amy's orders was we had to use Cracker Jack tonight instead of real popcorn. So hope it's okay. Make sure to enjoy that big surprise in the Cracker Jack. It's just getting better over the years. And our great producer, Jay Grunke, let's thank him too. So I don't know how many of you had a chance to see Tuesday night's class on the PPP program and loan forgiveness. It may not apply to some of you. For business owners, it's super important. And it was a great class, and we had a lot of people attend it. And this guy in the middle, this guy, Chris Finney, I'm going to have him back in the fall. He's done many, many courses for us. But all these lawsuits that have been filed all around the state, businesses, most of them, he's the guy that filed the suit against Kings Island, filed suit for Cedar Point. And in our meeting on Tuesday night, he very clearly said that this guy right here, Mike Wilson, had given him a lot of used in his lawsuit, and that's a great thing. So it was a fun class for those business owners that are struggling. So I get a lot of questions. People email us all the time. How do you watch the class that got on, that in case they missed it or something? All you do is go to empoweruohio.org. You go to the class. They're all in order. And then you'll just see a link that says to view a complete recording of this class, click here. So if you want to tell some of your friends some of the facts about COVID-19 that you learned tonight, that's how you're going to do it. And you can also, a lot of times people will give us their PowerPoints. Maybe Mike will share his PowerPoint with us. And if they do share their PowerPoints, we'll put those up in the exact same location for you to refer to. That was, I think, Mike, and I don't think I ever had a chance to tell you this, the most frequent question from your first class that you did. Can I get a copy of the data? So we've got 2 giveaways tonight. Not many speakers could get me to do 2. But we're going to do one giveaway for all the people online. And so one of my new favorite people to listen to is the great Ben Shapiro. If you haven't ever listened to him, in terms of COVID-19 facts, I think his are just about at the top of the list behind Mike's Facebook posts. And we're going to give away a copy of his new book that's coming out in July. It's called How to Destroy America in 3 Easy Steps. And for all those folks who are online tonight who want a chance to win, just go to the Q&A session where it says Q&A at the bottom of the screen and just type in your email address, and at the end of the class we'll let you know if you won or not. So just feel free to do that. That'll be the same way that you ask questions. And then we also have a giveaway for the people in here tonight. Bill, can you bring me up the bucket? When I was a kid, I used to read baseball biographies. This guy was one of my absolute favorite guys to read. What's that? I've got it. I've got the bucket. And Lou Gehrig, the incredible Lou Gehrig, when he was 24 years old, a reporter got him to write a series of columns that appeared every day in the newspaper. And he talked about his youth growing up, how he ever got to be a part of the 1927 Yankees, and how exciting it was. And for some reason, all those columns were lost, and they were found, and they've been put into this book. So we're going to give this book away tonight. So get your ticket out, everybody that's in the studio. And I'm going to ask our guest to pick a number. Our guest speaker. And that number is, it ends in 848. 848. And this, sir, your name is? Joe Capper. Let's give Joe a round of applause. I think you'll enjoy that book. One of the things we always like to do, I always like to do, is as I read kind of interesting articles that kind of make me think about things. This guy is one of my favorite. His name is Victor Davis Hanson. You may have seen him before. So I've got an article we'll pass out at the end on your way out. I'll ask Mr. Rolt if he'll be kind enough to do that, of Victor Davis Hanson's newest article, The Bitter Irony of Revolution. So that'll be for you on your way out. And I had just a few comments about our time off and really the things that have happened over the last couple weeks in Cincinnati and really around. The class, I want to talk to you about the EmpowerU class that we were going to do this semester, kind of the class that got away, the one that we weren't able to teach because of COVID-19. And I guess it was at the beginning of the semester, Betty and a couple of our board members said to me, you really need to see this documentary on a guy by the name of Jordan Peterson. And Jordan Peterson is a Canadian educator. So they bunkered me down. They made me go watch it. And you know, it was a fascinating watch. And Jordan Peterson, he's a Canadian educator. And he had found out that the Canadian Human Rights Commission had made a decision that they were going to outlaw the use of some very common words in our English language, and they were going to call it hate speech. And if you use those words in public, that you could be fined, you could be thrown in jail, and all sorts of penalties. And Peterson worked for, they said, you know, you can't talk about this. And, but he said, no, I'm not going to. And he came out and, Jay, is that me by chance? The static? Yeah, Peterson came out and just said, hey, you know, as soon as a government starts to tell you what you can say and what you can't say, then what will they do next? And what will happen to your liberties? And so watching I wanted to show you the documentary so much, the Peterson documentary, because his message was so important. And that important message is, don't be politically correct. No matter how hard it is, in these days, no matter how hard it is, you've got to tell people what's on your mind and what you're thinking. There's really not a more important message that I could share with you tonight. And when I got done watching that documentary, which is on Amazon, I kind of made a commitment to myself. I'm going to try to stay true to it. And I think I have to a certain extent. You know, the abuse of property we've seen in Cincinnati, the county, and the city over the last 2 weeks has really, it's just been shocking to me. I just encourage you to speak out against looting, speak out against criminal behavior, speak out for what you think is right. My true hope for all those people doing all that damage is that at some point in their lives, through their own hard work, they're going to have a chance to acquire personal property and enjoy it like so many other people have, and maybe they'll stop some of their behavior. But while I'm not being politically correct, I just have a few other things I wanted to share with you. And even though we have a few blips, I'm just so glad to live in America, and it's just such a great place to be. And even if the soccer players aren't going to stand during the national anthem, hopefully we can whip them back into shape. And we're just all so lucky to be here. You know, I really haven't met that many racist people. I really haven't. I've met a lot of people in my life, but I haven't met very many that I would say are just really racist. Maybe I've just missed them, but for the city of Dayton last summer found out that they were going to have a convention of white supremacists come to Dayton, and they got so $650,000. Now think about that, $650,000. That's more than the city of Cincinnati spent during last week's little series of fun downtown. So they spent $650,000 protecting their city, and a total of nine white supremacists showed up. 9. So that parallels. I don't want to say it's not a problem. 9 is a problem, but the numbers don't make sense for me, and I feel like I just need to say that, and it's whether it's the politically correct thing for me to say or not. Virtually everybody I bet in this room is as upset as I was to see that guy with the knee on Mr. Floyd's neck. It was a terrible thing. You know, I'll think about those pictures for a long time, and they're ugly, ugly pictures, ugly things to think about. But, you know, if you want to look at numbers, I know that's what Mike's going to talk about. Last year, and you may have heard this number, it's been thrown around all week, really 15 people that were unarmed suspects were killed by the police in this entire 325. I would so have us be spending time on all these people getting murdered in all these big cities. I mean, the numbers are staggering every day. And what I'd even love more is for the people that live in these big cities like Cincinnati to hold their elected people accountable for all those people getting killed. And about the police, oh yeah, about the police. Well, sometime we're gonna need them. I'm gonna need them, you're gonna need them, we're all gonna need them. And this whole idea about defunding the police has gotta be the stupidest, craziest, ridiculous thing that I've ever heard of in my life. And I hope that if you're gonna follow that not being politically correct mantra over the next few weeks, that you'll say that, because there will be a time, and that time, as we saw in the city of Seattle and other areas, will be soon. I just encourage you not to be politically correct. I encourage you to tell people what you think, do it peacefully, and be empowered by it. And the fun thing is, when we get back for our 20th semester of EmpowerU, which will start on September 22nd, Betty's so excited she wants me to move it up a few weeks, we'll talk a lot more about things like this and about big subjects that are really going on all across the country. So with that in mind, on to tonight's class. I'm going to introduce our 2 speakers. We're going to put a table for them to sit down at, and then we're going to turn things over to them. So Mike Wilson is a Cincinnati native and proud graduate of St. X High School and the University of Cincinnati. His degree is Applied Mathematics, which have served him well as CTO, Chief Technical Officer of Interlink Cloud Advisors, a local Microsoft-focused consulting firm. Mike has stepped back a lot from his political activism, but founded the Cincinnati Tea Party in 2009 and quickly built an organization that became one of the largest and most respected grassroots organizations in the country. Mike was also instrumental in leading successful grassroots efforts to amend the Ohio Constitution with the Healthcare Freedom Amendment in 2011. Dr. Bulas, this will be his first time coming to an EmpowerU, and we're really, really glad to have him here. He received his BS in 1985 and his MD in 1989 from The Ohio State University. He completed his internship and residency at the Medical College of Virginia in Richmond before returning to Ohio. He completed a fellowship in neuroradiology at the University of Cincinnati in 1984. He's practiced medicine in Cincinnati, Ohio since 1993, and he served as director of interventional neuroradiology, and the director of magnetic resource imaging at the Christ Hospital for 24 years. The primary focus of his career was stroke prevention, and he's lectured extensively on the subject from lifestyle modification to surgical and endovascular intervention. Dr. Bulas also served as a principal investigator on multiple national and international clinic research trials. In addition, he's lectured extensively on free market and socialized healthcare solutions for over the last 15 years. We've got two great speakers tonight. Just give us a minute to set the table up, and we're really glad. Anybody also, as we start hearing Mike and Dr. Bulas' presentation, if you have a question, make sure to go to the bottom of your screen and just ask the question. And Mike, would you prefer that we kind of feed the questions in throughout the presentation or wait till the end?
I think probably a combination of both.
Okay, excellent.
Thanks, Dan. Appreciate it. Check 1, 2. Check 1, 2. Get the audio.
Test this.
Check 1, 2. Check 1. There we go. All right.
No, not yet. I'll wait till.
All right, as soon as they get our PowerPoint up there on the screen, we'll get rolling. In the meantime, I'm going to apologize ahead of time for the math, right? So we're talking about statistics and data and all that kind of fun stuff. So I'm going to do the best that I can to explain it. If some of it isn't clear, please feel free to ask questions. Definitely want to make sure that we're communicating the best we can as part of that. Math isn't always fun, but this is one of those cases that it's useful. And what we find here when we look at some of these numbers as we dig into what's going on in both the state of Ohio and across the country, is that, we know that you can lie with statistics, right? Just by how we look at things, right? How we present things, how we talk about it, how we emphasize one piece of data over something else, right? And so we'll see that I think a lot of what's gone in Ohio here, right, is that you've seen a lot of that in action, right? We've seen them emphasize the date that things are reported versus when the date of things occurred. We're going to go through and we're going to show you kind of the real numbers, right? How you actually can look at this and understand the direction that we're heading, the numbers that are most important, and what the implication is for policy here in the state of Ohio and across the country. So thanks so much for everyone being with us today. And I am going to go back and revisit a few slides. So if you were with us back on April 14th, you're going to see a few things that we talked about back then, because I want to show you how things have evolved since. And at the same time, for those who weren't with us those days, I want to kind of catch you up on some of that as well. So I wanted to start by going back and revisiting the models, because that's how we got here, right? The reason that we ended up in lockdown, a significant part of the country, right, was shut down, had a lot to do with the Imperial College model, right? So the number that was bandied about in the media was that if we don't do anything, we could have 2.2 million deaths, right? And to a large extent, that if we really were headed towards 2.2 million deaths, that's something we probably should have taken measures to go through and intervene, right? I don't think anybody would really dispute that. That's a big deal and a much bigger number than normally die in America on a regular basis. All right, but the challenge with a lot of these models, right, as we've seen, is obviously that is not proven to be accurate. We're approaching 120,000 deaths in the United States right now, is that model didn't go through and take into account the fact that people are going to change their behavior. Right, that 2.2 million estimate was essentially assuming that while your friends and neighbors and family were dropping dead around you, you were going to keep carrying on like business as usual, right? And what's interesting to me when you actually look at who has had the most success in terms of predicting the course of the pandemic, right? It's not people that are approaching this from an epidemiology perspective. It's people that are approaching this from an economics perspective, right? Because those are the people that are studying the science of human behavior and how people react and how people change in response to incentives, right? And I found a very simple model that just accounted for that feedback, right? As people saw, right, they responded to their own death rate within their, their community, right? And as that death rate went up, they would correspondingly go through and lower their, their contacts with other people. They'd be a little bit more distant, take fewer trips out of their house. And guess what, right? You end up with a graph that almost comes into a straight line, right? Okay, where you have kind of a steady state of infections. Death rate goes down, people go out more. Death rate goes up, people stay in more, right? And again, that's how the real world works. So they did also do a variation of that model that included very strong mitigation measures. And so by that, they're talking about like the actual government level interventions. So we're going to close schools, we're going to close lots of businesses, things like that. That model predicted 192,000 deaths, right? We're not on track for that one either, right? So they got this wrong on a lot of levels. The other early thing that we heard from were Drs. Fauci and Drs. Birx. They were advising President Trump on the COVID-19 response, and they said that they were looking at a number of models and kind of gave a range of 100,000 to 240. So at least we're a little bit more realistic, right? So the other big model that was on the scene was the IHME model from the University of Washington. And this is one that got a lot of hype because this is the one that was doing all of the predictions around how we're going to run out of ventilators and our hospital systems are going to be overwhelmed. The earliest version of this model that I could find predicted 93,000 people, right? Or would ultimately pass away. What's interesting here was that was in response to some of the more recent data. All of these models started with data from China, data from Italy. And as we know, a lot of the data in China didn't necessarily translate to the rest of the world. We know China's not always honest about that stuff, so there could be a lot of reasons for that. But the IHME was trying to go through and essentially predict just based on the current outcome. It's a mathematical technique called curve fitting, right? We're looking at the progression of the pandemic, right? And then trying to go through and predict based on that. What's interesting there is that initially they actually underpredicted, right? So those numbers got as low as 60,000 before kind of coming up to a little bit more realistic numbers, right? But again, even over the course of the pandemic, okay, we're still updating numbers. We'll start learning as we go. And I think the biggest thing that I want you guys to take away from this today, right, is that this is the first time, I think in all of human history, okay, that we've had this level of focus on any kind of scientific research process. This is how the sausage is made, right? People make guesses, people make assumptions, they do experiments, they do studies. Some people get it right, some people get it wrong. Some people make up databases and have studies about hydroxychloroquine that have to be retracted because it was all BS. We know that kind of stuff goes on, but the difference is that the media is there, watching right now. This is obviously very relevant for everybody. And so the goal for tonight is to try to cut through the BS. Okay, give you guys some data that you can understand what is the risk to you, what is the risk to your family, and what should we do from a policy standpoint. So for me, I started this by just sanity checking the models. I heard that 2.2 million number, and I said, okay, is that realistic? Because I didn't go into this with any background in infectious disease. I'm not an epidemiologist, right? I'm a technologist by trade, but I work in data. And so, for me, I went through and I said, okay, what data can I find to go through and sanity check this, right? So the one place that we had widespread testing available at the time was the Diamond Princess cruise ship, right? We had an outbreak on the cruise ship, and of the 3,710 people that were on there, nearly all of them were tested. So this is a great, almost little natural experiment that existed to go through and figure out how does this virus progress in an enclosed environment and how deadly is it actually. So out of the 3,710 people, 634 became infected. So we ended up with about 17% infected and 1.1% ultimately ended up dying on the ship. So I took those numbers and just applied them to the United States, right? And did some numbers that were a little bit higher, some numbers that were a little bit lower, just to give me a kind of a frame of reference for what's realistic. So what I saw that if we're an infection rate of 50% and the death rate was 1%, if 1% of those people ended up passing away, we're talking about 16.5 million deaths, right? So 2.2 million, okay, maybe that's not outside of the realm of possibility. But if we take that 17% infection rate and 1% death rate, okay, we're down at 561,000, right? And as I'll show you later, we're seeing that the estimated actual death rate is actually lower than that. We're actually a little bit closer to that 17% and 0.25%. We're on track for about 140,000 deaths, which is interesting. I think that's a little bit more than a coincidence, what I was finding. Right, so we already talked a little bit about why the models kind of got things wrong. But I'd be remiss if I didn't go through and show you the abomination of Ohio's models. So this was the first model that was released by Ohio State University's Department of Epidemiology. And they released a prediction here of if we did nothing, okay, 62,000 people would be infected per day at its peak, right? And we would have a peak in the early March time or the mid-March time frame. But if we took strong mitigation measures, we would have a peak of 10,000 cases per day, right? And that would be, you know, a little bit closer to mid-May. That obviously didn't come to pass, right? So they, even a week later, they changed their projections from 10,000 cases per day down to 2,000. That still, okay, even seemed to be too much. And that's actually a big part of what started me on this journey. On April 5th, their view of the data was that we were going to peak at 2,000 cases per day, right? And I could tell you that on April 5th, we were already seeing the curve flatten out, right? We were at about 400 cases per day at that point, okay? And there was almost no scenario that we were going to hit that 2,000, right? So that made me question what was going on with the rest of the statistics, so we started to dig in on that. So here's where we're at June 11th, all right? So this is a snapshot of Ohio's COVID-19 dashboard showing the key metrics that the state's tracking. And I will tell you, this is their key metrics. This slide is almost entirely useless, right? It's good because we have totals, right? Totals are important. We want to know what the total number is. But in the end, okay, the decisions that we're going to have to make about policy come back to the trend, right? Is it increasing? Is it decreasing, right? And so if I look at this and I know nothing else, 40,000 looks like a really big number, right? That's a lot of cases. Right? We've got 2,490 deaths. 6% of people have died, right? Well, what that actually means is that 6% of cases that we have identified have died, right? We don't know how many people actually have the infection, right? Because we're not testing every single person. We can see here that, you know, they've expanded the definition here to include probable cases, right? So again, for people that pass a clinical diagnosis, but that don't have the, that actually haven't had a test for whatever reason. I understand back when we had a big testing shortage that actually made a little bit of sense. Now that we seem to have so many tests that we get days where we have 3% positive tests, that seems to me that we have a few extra. So I'm trying to understand why we still have probable cases in this day and age. Again, age range, meaningless, 1 to 109. Okay, it can affect everybody. The median age is 49 for being infected, but they don't tell you that that's vastly different for dying, which we're going to get to. And again, the number of hospitalizations and admissions, those are actually a little bit more relevant, right? Because again, if you're sick enough to actually have contact with our medical system, those are numbers that are pretty important that we can use to go through and determine. And again, the total number of tested, 509,000, which is a huge number, right? And it's come a long way since we last got together on April 14th. And then the last number, and again, this one's moderately interesting, but the total number of healthcare workers, 15%. So that means that out of all of the infections that have occurred, about 15% of those were the people on the front lines that were treating them, right? And again, so we understand that the disease is infectious in close contact like that. And so, you know, again, the most important thing for us to understand is how is this infection progressing in the wild, right? So again, for trending purposes, I care a lot more about person-to-person transmission in a room like this than I do about how, you know, what that transmission looks like in a hospital clinical scenario, right? All right, so here's where we're at from a case, hospitalization, and death statistics. All right, so Ohio breaks the numbers down. And again, you have to go dig. Some of this stuff's there, but you have to dig a little bit. You have to put stuff in the spreadsheets, do a little bit of analysis here. All right, but it breaks it down by age group, and I think this is important, right? If I show you one slide today, this is the one that I'd really want you to take away, all right? Because we see here, age 0 to 19, 2,000 cases out of the total, right? Out of those, only 100 have been hospitalized, right? And the number of deaths is exactly 0. Over 40,000 cases in Ohio, we have 0 deaths, ages 0 to 19. Right? This virus does not attack the young, not at all, right? And you can see that even as we get older, the number of deaths goes up slowly, right? But for the folks that are in the more elderly age ranges, this virus is dangerous, right? But not in every single scenario, which is interesting, all right? So we can see here that we look at this, that, you know, 80 plus is 4% of the population in the state of Ohio, 4.2%, but it comprises 53% of the deaths, okay, for COVID-19. Right now, what's interesting is, right, well, we know that, again, unfortunately, elderly folks, their life expectancy tends to be shorter at that point. 80%, I think for 80 plus, I believe the number is they represent 24% of all deaths in a normal year, right? And so again, if you get the virus, so this slide will go through and take us through, if you actually get the virus, right, and you get to the point where you're tested as part of this and you get a confirmed diagnosis, how likely are you to end up in the hospital or obviously worse, passing away from the virus, right? So if your age is 0 to 19, you have a 5% chance that you're going to end up in the hospital if you get diagnosed, right? Now, again, that means I obviously have to have enough symptoms to have contact with the medical system, right? If you're home and you're asymptomatic, your risk is basically 0, right? However, if once I get to 50 years old, if I get diagnosed with this, I have about a 1 in 5 chance of ending up in the hospital, right? And about a 2 in 100, 1 in 50 chance, of ultimately passing away, right? So we definitely see that increase in risk as you go through and get older. For 80 plus, again, if you get the virus, there's a good chance about a 1 in 3 chance you're going to end up in the hospital or ultimately pass away from that. Right. And again, this data is super important because everyone is going to have to look at what is your individual risk factor and what am I willing to take on from a risk standpoint, right? Am I willing to stay home and locked in my house to go through and protect myself, right? Am I willing to go through and, what am I want to do to go see my family? What do I do want to go see my friends, right? Everyone has to make that decision for themselves, and it is not going to be the same from person to person, right? And so when we look at these numbers, a one-size-fits-all policy to this state and to this country doesn't make any sense at all in my view. All right, so let's talk about how we actually get what the IFR is, right? So in epidemiology lingo, right, we have a few terms here that we want to go through and define. So the first of those is the case fatality rate. All right, so this is the number of deaths divided by the number of known cases, right? In Ohio right now, that case fatality rate is 6.2%. And when we talk about this, we can talk about either a naive case fatality rate or a age-adjusted case fatality rate, right? So for us in the state of Ohio, that 6.2% is a naive case fatality rate because all I'm doing is deaths divided by known cases, right? A better way to go through and do that would be to go through an age-adjusted, in which case that 6.2% would actually end up dropping considerably once we account for the fact that the young comprise a significant portion of the population. All right, but yep, question there? Yeah. Yeah. So the question.
Georgia, could you repeat that?
When you are giving these statistics, is it over what period of time? Is this a number of deaths in a year or since it started or per month?
Yes, everything that I've talked about so far has been the start of the outbreak in Ohio. I will have a few other things that are different, and I'll make sure that I kind of give context for what the timing is on that. It's a good question. So for everything we're talking about right now, this is the just for the duration of the pandemic so far, all right, in Ohio. So the infection fatality rate is what we really want to know, though. So if I get infected, what is my risk, right? The problem is that's really difficult to know. We're never going to actually know that because it's impossible for us to go through and test literally every single person, okay, in order to find the universe of potential patients on that, right? So I think we've got a pretty good handle on the deaths, but a terrible handle on the actual infections or the total number of infections, right? So we've got a few different ways that we can go through and look at this to try to go through and do an estimate, right? So one of those was the Diamond Princess experiment, right? So that would, again, we had a closed environment that we had, almost 100% of the people there that were ultimately tested. So that's a good way to go through and take a look at it. Another one that we had right here in the state of Ohio was a couple of prison outbreaks. So in Marion County and Pickaway County, we had essentially the virus kind of went like wild within those. And as part of that, once they started noticing that there were a number of cases in there and people were starting to get sick, they made the decision to test everybody inside of those facilities, right? And so, we obviously understand that a prison isn't a representative sample, right? Those people tend to be probably less healthy than the average population would look like. But when you go through and you do an infection or a case fatality rate for the prisons where we tested everybody and we had a chance to see the duration of that virus, it's 1.2%. That's the age-adjusted version of the case fatality rate for that. And so again, to me, those numbers pretty much tell me that just over 1% is the upper bound, right? We don't have any good examples that show that this is more infectious or more deadly. But again, we understand that those populations didn't represent, essentially kind of the general population. Right, so the other main way that we can go through and figure out what the infection fatality rate is, is to look at the number of people that have had the virus. So essentially to do antibody testing, right? So as you go through and get infected by the virus, your body will produce antibodies, right? And we can go through and do a blood test to determine whether or not you have those in your blood, and therefore you've been infected. Now, again, there's some challenges around timing on those and how long it takes for that test to ultimately show positive. But what you can then do is extrapolate from there. Okay, if this population has 15% of people that have had the virus, okay, then we can start to go through and do some translations into the general population. So by now, okay, we're up to, I've seen things that were released in New York City, Boston, Santa Clara, California. There's a lot of different geographies that have gone through and done this testing, right? And so what we're finding here is that the implied infection fatality rate from those is somewhere between 0.1% and 0.8%. Right, and the CDC last week, again, not that they've covered themselves in glory with the way they've communicated as part of this, but I do think this number is very reasonable based on my research. Their best estimate for the true infection fatality rate is 0.26%. Right, and that's, again, that is super important, because when we talk about what should our reaction to this virus be, okay, if this is something that's like a normal flu season, right, which is, again, in the 0.1 to 0.2 range, then the answer is we really shouldn't do anything different than we normally do in a flu season. If you're at risk, you stay home, right? You wash your hands more, okay? You socially distance yourself without being told by the government. And again, what we're seeing here is that this is only marginally more risky than the flu. It is more risky, right? But only marginally so. And again, we also understand that it only affects, the elderly population more than others. And again, that's something that we even see that in nursing homes. So just to see that kind of in graphical format here, you can see the, it's a little small up here. Hopefully those at home can probably see this better. But what I will show you here is that the orange line up here, let me get my pointer. There we go. So this orange line is the case fatality rate in Ohio for 80 plus. Okay, the center line here is the estimated infection fatality rate that I calculated from the prisons. Okay. The thing on the right here is 2018's all causes mortality rate, right? So the comparison for you is the worst case scenario for Ohio. The true worst case scenario for Ohio is the prisons. That's the orange bar. That's the risk associated to the people in those age groups. Okay, the one immediately to the right, that the almost brown looking bar, okay, is the one that essentially what's your risk of dying in the next 12 months anyway, right? And so we can see here that COVID really isn't that much worse than you would normally expect, right? And that's, again, where we don't have context to these numbers. That 40,000 looks like a big number that we talked about for the total number of cases, right? The 2,200 odd deaths that we have, or 2,400 deaths that we have, that seems like a really big number, right? All deaths are a tragedy, right? But unfortunately, death is also a part of life, right? And we have 10,000 people that die in the state of Ohio every single month, right? So again, let's put this in perspective. The 2,500 cases that have passed away, right, as part of this, okay, we all mourn for them. Those represent somebody's loved one, and that's not a good thing, right? But again, during this 3 months of this pandemic, we've had 30,000 people die for other causes anyway, right? And so again, we need to go through and kind of understand just what this threat is. And like I said, with regards to where this is occurring, 71% of those deaths have occurred in nursing homes and long-term care facilities. Right? When you take away that and you take away the prisons, we're down to about 500 deaths that have occurred in the entire rest of the state during this time. Right? And again, Rob will talk a little bit about this when he gets to more of the medical side of how the transmission occurs. But for the most part, okay, the place that you are most at risk is when you are in sustained contact in shared airspace with somebody else who is infected. Right? And if you are outside of those scenarios, your risk is pretty minimal. All right. So excess mortality, right, is an interesting concept, right? Because we know that people die on a regular basis. And again, if all COVID-19 is replacing people that would have died from the flu, no big deal, right? It's the same thing. But if those deaths represent excess deaths, deaths that wouldn't have occurred otherwise, then yeah, that would inform our policy response. So this is a slide, and again, I know this is a little bit tiny up here for you. I'm not asking you to read anything that's up there, but you can see the little red lines up there above the, so like the straighter, like blue-gray area underneath. So this is from the New York Times, and they've tracked, they've kind of gone for a number of geographies, the United States amongst them, which is kind of the second one up here at this spot. 66,000 people die a week, right, in the United States, and the red line represents excess deaths over normal, right? And you can pretty clearly see the impact of the COVID pandemic on that, right? And so again, that's something where, as we talk about this is an important thing for us to keep in mind when we talk about policy response and how we should deal with this. But in almost every single one of those cases, you're seeing those numbers come back down to normal, right? Which tells us that we're most of the way through what this pandemic is going to be. All right, so let's get into Ohio. I'm going to run through a few slides here. This is Ohio, and I'm going to show you a little bit about how I wouldn't say lie with statistics, but definitely mislead with statistics. So this is Ohio's COVID-19 deaths, right? So this is information that is updated through today, right? We can see that we had a peak on April 28th in terms of 139 deaths that were ultimately reported on that day. All right, but that day, those 139 deaths that came in, those don't represent 139 people that died on April 29th. That is, the state reported 139 deaths, okay? And those deaths were distributed over previous periods of time. So what I want to do is overlay a second line here, and this is the red line, right, that's kind of underneath here. This red line represents the deaths by death date. That is a very different series with a much lower peak, right? And again, when you see Governor DeWine and the now deposed Dr. Acton at their daily press briefings, okay, the number that they emphasize is the reported date. Now understand, this is normal for there to be a delay in reporting. It is not nefarious, okay, we understand that. And I can tell you that when I've gone through and done analysis on this, that lag is very predictable, right? So I can tell you, again, that we're gonna have almost 0% of today's deaths in there. We're gonna have about 30–40% of yesterday's deaths, about 80% of the day before, and then it just backfills in over there. And part of it is we've got hospitals that have their own internal reporting and accounting systems. We've got various long-term care nursing facilities that may not be connected directly to the state. There's lots of different mechanisms for those dates to come in. So don't think it's nefarious, but again, they're not emphasizing the right things from a messaging standpoint, right? And a lot of the things here, the declines that we talk about in some of these cases are a lot more pronounced when you look at things by death date, hospital admission date, or case onset date. Right, so this is a bit more of a zoomed in version of the deaths by death date. And again, you see the very clear peak that occurred here.
Mike, can I ask a question?
Yeah.
On that previous slide with the lower graph, what was the most number of deaths in one day for those people who can't see that in the back? No, on the previous slide.
Well, it's the same graph, just zoomed in, right? So it was 139 was the number of deaths reported, okay? But that same date where we had that big number, okay, it was 62 was the actual number that passed that
So
day.
62 was the most number of people that have died any day
Right.
in Ohio.
In the state of Ohio, absolutely. So it's
Thank
a very
you.
different series. One more question?
So you mentioned about the numbers that Dr. Acton would give, and then a reporter might counter that. Like one time she said there were 50 deaths, and then later they said, well, there were only 5. Does that have something to do with that chart you were showing?
Yeah, that's a big part of it, right? Because again, they're reporting just whatever information has come in versus what actually occurred on that day. So there's always been a disconnect on every single day, and that's a big part of why. And again, the media, they're finally starting to catch on a little bit and start to ask better questions about that, but it's not been great or consistent in that respect. But it's exactly that dynamic, right? And so just to show you a little bit about how this works, this is a graph that I showed on April 14th. And this graph shows the deaths by death date. So it's just an earlier version of the same graph. But I want to show you how this updates over time, just to show how that data comes in and backfills. All right, so the next slide is the same graph, right? But it shows the version of that graph on different days. So again, the orange line there at the bottom, all right, is what we knew on April 14th. All right, the lines above that are what we knew respectively on April 21st, April 28th, and then May 26th. Just by that point, essentially the numbers were finalized, right? But you can see there the 3 or 4 days prior to April 14th, there were some pretty significant changes there. What looked like a downward trend from the beginning of roughly April 8th going down to April 14th turned into a pretty consistent upward trend, right? So again, we want to make sure that we're accounting for this kind of stuff in our data and looking at that. And so I've tried to always, to the extent that I'm doing trends, I'm going back 3 or 4 days and just kind of assuming everything in the short term, right, isn't something that's going to be accurate to make a decision on. All right, next slide. Okay, so cases, right? So in the end, deaths are important, but the deaths lag cases, right? It takes time for someone who is sick and diagnosed to ultimately pass away if they're going to. All right, so looking at cases is a big deal, right? And in the beginning of this pandemic, that was a very useful thing, right? Because they were very consistent about how they were reporting cases. That's changed a little bit. But this is the graph of daily case reports, okay, through June 11th. And we can see, again, a big spike on this one that occurred in the late April on that one that was tied to testing in the prison. So I mentioned the prison experiment where we had a number of folks there who got sick in that one. You had some very targeted testing that drove like a huge spike, right, and the number of tests there. So again, same version of the graph here, this time by illness onset date. All right, so again, very different pattern, and you can see here the trend downward at the end, right, as we get into June is much more pronounced, even accounting for the lag. Okay, you can see a much more clear decline here because a lot of the number of new cases that are being reported, okay, there were actually 2 cases that were reported today that were actually had a infection date of February 1st, right? But those were included in today's numbers, right? And again, without looking at that and without knowing that context for that, right, we can't make good decisions, which is a problem. All right. So this again is kind of the yes, okay. Yeah, so this one is a couple of things here. So this one actually has the adjusted death rate. And again, this is where, so we, like I mentioned before, right, with the prisons, we had this big uptick, okay, in the number of cases that were reported that had nothing to do with new infection, okay? People that would, I think it was 70% of the people that ended up being sick in the prisons, okay, were asymptomatic. So again, had we not had an outbreak that we decided to go test everybody, those cases never would have shown up. So again, for trend analysis, I remember looking at these numbers at the end of April and people were in panic mode. Oh my God, we're at 1,700 new cases today. The numbers were skyrocketing. This infection is out of control, right? And so I said, something's got to be wrong. And I started looking at the county numbers and all of those new cases were concentrated in 2 counties, right? So then I did a little bit of research and found out that they were testing the prisons. But if I was just looking at this and I didn't dig into the data to understand what was going on, okay, I would have absolutely thought the infection was spiraling out of control. And that's where having knowledge around what the numbers mean is super important. Yeah, and so cases basically they're just not good for trend analysis anymore, right? So in the beginning of this pandemic, it was pretty clear that because we were rationing tests, in order to get tested, you had to be fairly sick. You had to have contact with our medical system. If we didn't have spare tests to go test random populations, right? So that's a problem. Our testing methodology has changed, right, as testing has become more widely available, right? And so again, without accounting for that, a big part of what you're seeing in other states right now where they have big spikes in cases, because they're testing more, right? If you test more, you will find more cases. Absolutely. And the second part here is that our data set now includes not just the what they call the PCR testing, that's the nose swab that they stick in to see if you have an active infection. It also includes antibody testing, right? And again, so those cases that were reported today on February 1st, those obviously weren't people that came in today and got a nose swab as part of that. Those were people that got antibody tested, and then based on their clinical history, they assigned an illness onset date going back to February. Right. In fact, we even have in our data set now in Ohio, we have 20 cases that are now in the data set from prior to February 1st. And again, those are all antibody tests that come back. And again, I don't have an issue with Ohio reporting. I think it's actually good that they're including those. Okay, but they have to understand the context. Those should be separate data sets that they publish, right? And they explain what's in those. The fact that they're putting those in a single data set without explaining the difference, okay, tells me they're being deceptive and I don't like it. Right, and again, just to show you the difference in testing here in the state of Ohio over time, this shows the number of tests that have occurred And so the bar graphs where that you see kind of increasing left to right over the course of the graph are the number of daily tests occurring in the state of Ohio. And again, for those who can't see the numbers, we were down well below 2,000 tests per day in the early part of this pandemic back in, that was the late March timeframe that the state started publishing those numbers. Right now, we're pretty routinely passing 10,000, 12,000 cases a day. But as we've done that, our positive rate on the test, which is the line traveling left to right across the, ignore the three very high spikes at the very left there. Those were days that they just didn't report any negative cases. It was just a reporting clerical issue. But since then, you can see, as we've tested more, right, we've had a pretty clear decline in the positive rate. And so again, it's been more than 2 weeks at this point since we've actually had a day where more than 10% have tested positive, right? Most recent average has been 3 to 4% almost every single day. And again, that's another indication that as we ramp up testing, you know, again, that we're going to go through and find more of those cases, and that they're working really, really hard to go through and try to find those. So when I really look at trending at this point and try to understand the trajectory, the data set that I use at this point, okay, that I think is the most important to understand, is the outbreak increasing or decreasing in a state, is hospitalizations. Right? In Ohio, finally, and again, remember, we were supposed to flatten the curve. It was about protecting our healthcare system. And that was something that I think everybody got and everybody wanted to go do, right? It was important because we didn't want to end up like Italy. We didn't want to end up like New York City where our healthcare systems were overwhelmed, right? And so the metric that they should have been basing their decisions off of in Ohio, the number one thing was the current load on the hospitals. And up until about, 2.5 weeks ago, they didn't post that number on a daily basis. What they posted were new hospitalizations, right? They didn't even tell us hospitalizations by admission date, right? So it's taken time for them to go through and catch up and tell us what was the number one number, okay, that was related to policy in the state of Ohio. So this graph is the number of hospitalizations in the state, current hospitalizations, and we can see that that number has come down by about 1,100 per day back at the beginning of May, down to just over 600 at this point. We've almost cut that number in half. And that to me is the clear sign, okay, that this pandemic is on the decline in the state of Ohio. Right. So what happens though if we have if we open back up, right? So a significant, portion of the state has reopened, right? We haven't seen an increase in the state of Ohio, right? And I know the media wants us to go through and scare us. Remember what happened in Florida? Okay, the governor, they were one of the last states to lock down. They have kids out there on the beach, and oh my God, it's going to be terrible. They're gonna spread this because of spring break, right? And then they started opening up way early. In Georgia, they had kind of the same thing. They were one of the first states to go through and reopen, and there were, the talking heads on TV saying, all these lives, all these deaths are going to be on your hands, Governor Neal, right? I mean, they were preliminary saying that he was basically, it was almost like he was out there just like murdering himself, right? That was the way the media wanted to portray it. So on this slide, okay, are graphs in 4 states. Okay, these are 4 of the states that have opened up earliest in the country. So, and again, there's slightly different data here. 3 of the states report current hospitalizations, right? So for Wisconsin, Colorado, and Georgia, I could actually see the number of people in the hospital on a daily basis, which is good. Florida, unfortunately, does not do that. So I had to go through and kind of do it based on new hospital admissions. So it's not perfect, but it still gives you an idea what the trend is. But again, as you can pretty clearly see here, Wisconsin is one that has trended down. Georgia is one that has trended down. Colorado is a little bit more flat, but again, the overall trajectory is slightly down within that area. And Florida has been flat at best, right? So in these places right now where they're talking about this big increase in testing, right, and the number of cases that are being reported, remember, it comes back to the testing. Unless you're seeing a corresponding increase in hospitalizations, which will ultimately lead to an increase in deaths, don't worry about it. That's the media just trying to scare you. So with that, I'm going to turn it over to my good friend, Dr. Bulas, who is going to share a little bit of the medical side and help explain what some of these numbers mean and how we got to them.
Test. Is there a...
You're good, doctor.
I am? Okay, terrific. Pleased to be here. Kind of summarize what Mike said. Ohio is doing well. We have no stresses on our hospital, our healthcare system. We're trending downwards. Our case positivity rates are going down. So we've done our job as citizens. We've mitigated and protected when we're supposed to. And while we're no longer mitigating and we're actually opening up, we're continuing to trend downwards. So good sign. I'm going to talk a little bit more about why that is. But really what I'm gonna do is just kind of compliment what Mike has done. He's laid those numbers out there and we're doing fine. I just wanted to clear up though from a medical perspective, some of the issues that have been really muddied over the last 3 months and by a lot of misinformation that's been out there. I'm gonna talk about how the virus affects us, you know, what we've learned about treating it, how we're coexisting with it now, and where we go from here, okay? So I'm gonna skip forward through a lot of what we didn't know and jump into right now what we do know. And so let's pop into, yeah, slide 5. So I promise you, I'm not going to use a lot of hardcore science on you guys. That math killed me. I don't know about you, but I do appreciate guys like Mike, a lot smarter than I am. But I do want to talk a little bit about what this virus does and how it's different than influenza, because it is different. Don't let anybody tell you it's just the flu, because in those who are vulnerable, it's not just the flu, okay? Good news is the vulnerable are people with a lot of medical problems, what we call medical comorbidities, the elderly and the middle-aged with medical comorbidities. And those under 50 who are healthy, it's not really a disease that affects that population. But how does it work? Like any virus, it has to get into a cell in our body in order to infect us. And this is a virus that's transmitted. It's what we call a respiratory virus, just like influenza is, like the flu is. It's generally transmitted in a setting, usually in an indoor setting, with a cough, a sneeze, or prolonged talking, breathing, laughing, singing. And it's actually inhaled from another person's mouth or nose into our mouth, nose, or even into our eyes with COVID-19, okay? When it gets in there, and most of us, we do just fine. As Mike's shown you, the numbers are overwhelming. Even in the over 80 population, if you get it, you have an 86 to 90% chance of surviving it, okay? And we do that because most of us have immune systems which can handle these small volumes of virus that we inhale. It may get to the back of our throat or back of our nose, which is where it goes initially, but it tends not to go beyond that in most individuals. Now, I'm not going to really dig deep on this, but the reason why it goes to certain parts of the body is that this virus enters our cells through a little gateway. It's called an ACE2 receptor, and it's only in certain cells in certain parts of the body. It's in the back of our nose, the back of our throat. It's in our lungs, our heart, our liver, our kidneys, and the lining of our blood vessels. And that might seem to be worthless information, but you'll see it actually makes some sense. Looks like the battery is running low here, okay? And so for those unfortunate few who it goes beyond our back of our nose, back of our throat, it can make its way down into our lungs. And when it gets there, this virus is different than the flu because it can affect us negatively in 3 different ways. One, just like the flu or like any bacteria, can cause a pneumonia, which means it gets down into our lungs. You know, our immune system attacks it. Dead cells are produced. What we call pus, which is just your white blood cells mixed with dead cells, fills part of that lung. And we cough, we have a fever, but generally our immune system can take care of that. And COVID-19, SARS-CoV-2 being the virus that causes COVID-19, does that. But more importantly, it actually causes 2 other things that are a lot more dangerous than what the influenza or general flu does. One is it can really trigger our immune system into going overactive, what I call a hyperimmune response, where our body, where the virus is flooded by all these white blood cells and a lot of chemicals that are released by these cells. And that's called a cytokine storm. You might have heard that discussed in the press. And that's really more important than the virus itself. And in people who suffer with severe disease, COVID-19 disease, or die from it, it's more often than not caused by this inflammatory storm that our body has produced in response to the virus. Okay. The third way it's different than influenza, since influenza doesn't do that, the third way it's different than influenza is that it can affect the lining of the blood vessels. It can cause an inflammatory process to develop in the wall of your blood vessels and your arteries. And it can cause blood clots to form inside those blood vessels. And if blood clots form, they can clog that blood vessel up entirely. So if you think about the lung level, you know, you've got this little pneumonia, you have this cytokine storm, which is infecting that tissue and actually causes fluid to leak from blood vessels into those air sacs of the lung. So we're kind of losing airspace there, we're smothering a little bit. And then if blood clots form in these lung blood vessels, we can't even get the red blood cells, which carry oxygen, to the air sacs to get the oxygen. And so our body becomes oxygen starved. Not necessarily just our lungs, but our heart, our liver, our kidneys, and it could even be our brain. And these blood clots that form can actually occur elsewhere, and they can cause a heart attack or can cause a stroke. So it's very different. And I'm not trying to scare any of you, but I want you to know that this is not just the flu. And people say it's just not just the flu. It is just the flu for young people, but it's not necessarily just the flu for people who have other medical problems, okay? But now that we know how it affects us, we also know how to treat it, okay? At least in the severe diseases that affect the lungs and other organs. I do want to make comment now on what we know today in terms of treatment, a little bit on the milder forms of involvement with COVID-19. We had a lot in the press about prophylaxis, and actually I know a lot of docs and other healthcare workers that took hydroxychloroquine through this pandemic. I don't know of any myself who got COVID-19. That's not proof that it worked as a prophylactic. It may have, and there are ongoing studies looking at that prospectively and comparing it to people who didn't get it, but we don't know that. But anecdotally, there may be a role there, no more than anecdotally. Same thing with early infection. Do we have a medication that's been proven that once we get a positive test and we have a fever and we have a little cough, that we can take this medication and we won't get severe disease and we won't die? Well, we've seen a lot in the press about hydroxychloroquine used like that. And I know lots of docs have used it. We've seen lots of reports of 40, 80, 100 patients being treated. And the docs are reporting and the patients are reporting very good results. But again, these are anecdotal results. Do I believe that there's a role in this early phase with hydroxychloroquine? There probably is. But I don't know how significant that is, because a lot of these people would have gotten better on their own with their own immune systems. A lot of them actually had some degree of a placebo effect. I have a couple friends who put themselves on hydroxychloroquine. I told them I don't think you really have having symptoms related to COVID. They did a positive test, and miraculously within 4 hours later, they were better. So, we have to take these things with a grain of salt. But I do believe that there is some positive effect. We know it's an anti-inflammatory. It works with rheumatoid arthritis and malaria. There's reason for it to work. But we have to wait till these trials are completed. And it's going to be months to a year before we actually have those results. But we do have a lot of important data and important changes in treatments for those people who have more severe disease. And that's what's most important. We're trying to save lives. So those patients who develop shortness of breath or are detected to have low oxygen levels in their blood by having a little pulse oximeter placed on their finger, in these patients, we know now we have to work quickly, okay? And we need to get to them in general within 6 hours. And if we do, within 6 hours of being short of breath or having low oxygen levels, we're having terrific results compared to where we were back in February and March. And interestingly, it's all based on what I described initially, how this virus affects us. We know now that people aren't dying because of the virus, they're dying because of your own immune system kicking into overdrive and causing a cytokine storm. And if we can blunt that by giving people anti-inflammatory medications, which is a little counterintuitive. Normally with people with infections, we don't give them something to stop the immune system. We're afraid of that. Can make the disease worse if it's a bacteria or a typical virus. But with this virus, we do want to give them medications like intravenous steroids. You've heard of prednisone or methylprednisolone that we use for a variety of different conditions. That's really the #1 medication that we use now in these patients. We very quickly, within 6 hours, give them IV steroids. We give them another IV anti-inflammatory. Now, some people will get hydroxychloroquine first, along with a steroid to see if that works. But if it doesn't, we go to more potent intravenous medications, including something called Actemra, okay? And you see these pop up every week. There are more and more coming online that are having the same positive effect. But the key is very quickly, within 6 hours of having short of breath and having low oxygen levels, to get 2 intravenous anti-inflammatories in the hospital on board, give the person oxygen through a nasal cannula or through a face mask, not put them on a ventilator right off the bat. And very importantly, we also have to give them a blood thinner. And that blood thinner is what we give in the hospital called heparin. The one we take at home is called Coumadin generally, but heparin is what we give through IV. It works instantaneously, and that helps prevent our blood from clotting. My monitor's off, so if you see me look up here from time to time, you'll know why. And so the other medication that we give is an antiviral. So far we've given 2 anti-inflammatories, a blood thinner, and we give an antiviral. You've heard of remdesivir. It had a lot of press, just like hydroxychloroquine did. Dr. Fauci loves remdesivir. It's not a silver bullet, just like hydroxychloroquine probably is not the silver bullet, but it may shorten the duration of the infection, shorten the duration of being in an intensive care unit, and I believe there is a role. So we will give an antiviral. Might not be remdesivir, might be another. We have a whole host of them, okay? And very interestingly, we have to give people vitamin D if they have vitamin D deficiency. Vitamin D is very important to your immune system. And vitamin D deficiency is rampant in our population today, particularly in teenagers and young adults who don't go out in the sun anymore because they're on their phone or on the computer all the time, like my kids. But the bottom line is we found in studies in China that there can be a 50% increase of severe COVID disease if someone is vitamin D deficient. Very important. So we will check immediately when they come in with shortness of breath. They'll check their vitamin D level and they'll supplement quickly if so. And interestingly, vitamin C actually is another thing we're giving in high doses IV. We've actually been doing that with bacterial infections that get in your bloodstream for some time. We don't have a lot of solid proof on it because it's usually given in conjunction with all these other medications. But a lot of docs, including intensive care unit docs throughout the United States, are giving people high dose IV vitamin C along with the anti-inflammatories, the blood thinner, and the antiviral. Okay. So with this regimen, along with supplemental oxygen, we've brought our death rate and our rate of having to put people on ventilators way down over the last 3 months. So that's been our biggest strides in terms of advances in medicine. We also now have something called Cavalescent Plasma. So those people who've been infected and have developed antibodies are donating their blood, donating their plasma. And we've now demonstrated in the last couple of weeks that at least in the labs, these antibodies are stopping the virus. So we are starting to give it to people. We'll know long term down the line how good it works in the body itself. But we've developed great tools that are really bringing the death rate down and the ventilator requirement rate down. How about those people? What are we doing from a pulmonary standpoint? Well, we give them oxygen while we're giving them these medications. We're turning people on their bellies a lot more than we used to. Laying on your back, if you have something that's causing inflammation in your lungs, that water, that fluid, that pus is going to go to the back part of your lungs. So common sense, turn them over intermittently on their stomach and let that drain out. It's amazing how many more people didn't have to go on a ventilator because we started doing that. And if we do have to go on a ventilator, we've learned that people being put on low pressure settings, low oxygen pressure settings, instead of pumping high pressure oxygen, is causing a lot less harm and doing a lot more good. So much better off than we were 3 months ago with therapy for people that really need it with lung disease. I'm not going to repeat the stuff that Mike said, but the important thing to remember here is that this is a disease. Yes, please.
Hold on just a minute.
You mentioned how important it is that these measures are taken immediately.
Quickly, within
Now,
6 hours.
Anytime I've gone to the ER, you sit for 3-4 hours and nothing happens. Yeah. So how is this happening when the normal procedure is you go down to the ER and you sit forever? Can you address that? Oh, sure. Well, I mean, what you have to understand too is most of these people who come in with shortness of breath, that's not their first symptom, okay? And where their oxygen levels are low. Some are. Some come in too long, they just stayed at home and didn't complain about the fever and the cough they'd had for 7 days before that, okay? There's going to be cases where that happens, but the whole key is you're in charge of your health care. When you walk in the ER, you tell them, I have a cough, I've had a fever for a week, I think I have COVID, and now I can't breathe. And you'd be surprised how quickly they're reacting out of that. So that's all I can tell you. Always be your own advocate, and especially with this disease.
Question.
Yes.
So we've heard so much about hydroxychloroquine. If you walk into the hospital and you tell them that you want that, what will the reaction be? Will they say, sure, we'll give it to you? Will they say, what will they say to you?
Yeah, well, first of all, it's not your call to just tell them what kind of medication you want. You know, if you go in there and they see you're COVID positive, you know, they see that you have pulmonary symptoms, you're going to be moved very quickly to the docs that actually take care of that. If you just come to the ER and say, I want to have hydroxychloroquine, they're not going to give it to you. And they probably shouldn't until they do a workup on you, okay? So totally different thing. I'm talking about people with pulmonary symptoms, symptoms that are definitively lung involvement, which is low oxygen levels and profound shortness of breath, okay?
Thank you.
So I'm not going to repeat what Mike said, but the bottom line is we know this is not a disease of kids. Under 30, under 40, our case fatality or infection fatality rate, if you get that infection, your fatality rate is less than 0.1%, which is what we're dealing with influenza, okay? So it's not a disease of the young. Infection fatality rate is higher in those over 80. It is up as high as 14% if you look at different countries and in the US. But again, most of these people have medical comorbidities in addition to being elderly, okay? And those medical comorbidities are critical, both in the middle-aged and in the elderly. In fact, almost everybody who ends up having death caused by COVID-19 has one or two, at least one or two of these comorbidities, and that is severe chronic heart disease, severe congestive heart failure, severe lung disease, emphysema, other bad chronic lung diseases, chronic kidney disease, on dialysis or nearly on dialysis, people with chronic high blood pressure or hypertension, diabetes, and I mentioned obesity only because obesity is so much associated with pre-diabetes, diabetes, and hypertension, okay? And in fact, and interestingly, if you have pre-diabetes or diabetes and obesity, you have what we call insulin resistance. And that actually has been demonstrated to change that gateway, that receptor I told you about in the same cell membrane, and make it easier or more porous or bigger or wider or more easily accessible for the virus to come in. So all of these diseases, particularly obesity and diabetes, affect those receptors. So these are the things we have to clue into, okay? And those are the people who are really affected, and we know that well. All right, so here's a great slide. This is the most important slide from my presentation, okay? What do we know now about SARS-CoV-2 and COVID-19 disease? Outdoor transmission is exceedingly uncommon. Exceedingly uncommon. They don't talk about that. They tell us, oh, well, the warm weather and being outside is beneficial for you, but they don't tell you how beneficial it is, okay? So I'll tell you, there's been a couple studies that I will refer to here. One looked at 318 clusters of infection. That doesn't mean people being infected, it means clusters. 3 or more, maybe as high as 20, 30 people in a cluster, all having gotten infected from being in a certain place at a certain time. Of those clusters, out of 318, 1 was outdoors, 317 indoors. Another study, this was in China, they looked at 7,300 positive patients and did contact tracing to find out where they got it from. Out of 7,300 patients who got COVID disease, 1 out of those 7,300 obtained it outside. So it's extremely difficult, and it actually makes sense when we're outside and we breathe in the open air. Whatever volume of virus you may have expelled from your mouth is being dispersed into a very wide space. A little breeze can carry that, and when it carries it, it's not just carrying it in a bulk to somebody, it's dispersing it everywhere. A lot of different reasons, including the weather, the heat, the humidity, all can have an effect on how easily this is transmitted. So this is not a disease that's commonly, I'd call it rarely, very rarely transmitted outdoors. We know that indoor transmission can occur despite 6-foot spacing. I hate to tell you that here with our 6-foot spacing, but studies have demonstrated, including one in Seoul, South Korea, which has become kind of famous, that even in an office space that is 40, 50, 60 feet long, normal breathing over several hours in an office day can transmit it to everybody in that space. And that's because we have modern HVAC systems, we have airflow, and if you happen to be at the back, you know, where the air is drifting in and you're the one who infected, even if you're just doing normal breathing through the day, you could infect anybody in this room, okay? That's good because we're not seeing us all get infected, okay? But it's important. So there's no magic to the 6-foot rule, and we'll talk more about that in a moment. Transmission can occur despite mask wearing, okay? So, you know, is mask wearing good? Well, you know, as a doc, I wore a mask every day for 6-8 hours while I was doing procedures for a quarter century. Important there, because I'm trying not to infect or drop anything down out of my mouth or face on a person's body while I'm doing an intervention on them. Do masks work in the general population? Lots of conflicting data. We've heard they do work, they don't work, they do work, they don't work. Wear one, don't wear one, maybe wear one, okay? And so what I can tell you is this. If you have a mask on and you have COVID-19 disease, you have a high volume of virus inside of your throat, and you cough or sneeze, that mask is not going to stop that virus from infecting somebody in front of you, okay? It's been demonstrated. A cough or sneeze can come out at up to 12,000 miles per hour. That can blow right through those pores. It'll blow right out the sides, and it'll blow above, and it'll blow below your mask, okay? It'll be dispersed in a room, okay? And in any given room, if I cough or sneeze and I have it, I could blow particles all the way back to that wall without any problem at all, okay? Mask or no mask. Do I think it's helpful in some instances? Yes, I think that they do. Masks are helpful in people who are sick, who probably shouldn't be out anyway, but who are out in public. I think it helps by decreasing what we call the viral transmission load. And those healthcare workers who got infected, even while wearing some masks, while doing procedures, some of those procedures for an hour at a time, they're putting a scope down somebody's throat, they don't know they have COVID-19, and literally the virus is just pouring on them, despite they have a mask on for an hour at a time. Those healthcare workers died. A lot of them died. Made up to, early on, it was 25% of deaths were healthcare workers, and it came down to about 15%. But that viral load is important. You're not a healthcare worker, so you're not dealing with that day in, day out, 8 hours a day, 10 hours a day. But when we do breathe with a mask on and we're sick, we're infected, there's probably a lot fewer particles coming out toward the person in front of us than there would be otherwise, all right? Maybe a 40% reduction, maybe a 50% reduction, okay? So the bottom line is we don't know whether masks are really helpful in the long run in terms of changing the course of this pandemic, but in people who are sick, good to have them on. If they're at home with their family, good to have them on, all right? Very important, the last two items here. Asymptomatic transmission resulting in symptomatic infection of somebody else is very uncommon. This was a big firestorm this week. World Health Organization representative came out and she said that, actually the words she used were rare or very uncommon that asymptomatics ever infect anybody else. Now, they did walk that back a day later and said, well, we didn't quite mean that. And there's a lot of double speak. And I think that's because there was a great fury out there by people in control around the world and in the country who didn't want to hear that because they no longer could justify the lockdowns that we used in society. I believe that asymptomatics can infect other people, but I believe these asymptomatics have such a low viral load, they're walking around with it without knowing it, that when they do breathe some viral particles on somebody, it's such a low viral load that that person can handle it too, if they have a normal immune system, okay? And we do have studies that have shown that that can occur. It's not that it never occurs, it can occur. But I think it's probably uncommon to cause symptomatic infection in somebody else whose immune system is competent, who does not in the vulnerable population that we talked about. Very important. And I'll tell you why later. And lastly, transmission by school-aged children to adults is extremely rare. It may not even happen. That's how rare it is. Studies in a variety of countries, including in Denmark, that did contact tracing showed that an infected school child who had 172 contacts over several days, their teachers, the adults at home, all the other kids, before they finally admitted they were sick and found to have a very high viral load, none of those 172 contacts ever developed symptoms and none of them ever converted by testing to positive. And so it's pretty accepted at this point in time that school-age kids are not what we call asymptomatic transmitters of the disease. They may carry it, but they're not transmitters.
Dr. and Mike, we're starting to run a little tight on time. Can we take some questions? Because I know there's some people online that have a few questions they want to ask.
Sure.
Jay, do you want to handle the questions?
One person is asking about a recent Hong Kong study on hamsters and face masks, indicating that around 80% of COVID would be prevented if both infected and not infected were wearing masks. Is that a valid study, and do you believe those results are still good?
Yeah, I've read that study too and dug through it deeply. I mean, granted, it is a hamster study, and they just put masks on the cage, in between the two cages, one on the symptomatic one on the uninfected one, then on both. They did show, I believe their words were that they say 80%, it might have been 70% reduction, in the infection rate. I think, and like I say, I think there is a role for masks to reduce that viral load, and maybe that's what it took. Maybe it was the viral load that was reduced. There's a lot of data on both sides of this. And that's why I'm not telling you masks are bad, and I'm not telling you that you should wear a mask. I'm just telling you that for someone who is sick, for someone who has the virus, who's symptomatic, I think masks are a good idea.
Can I ask a question along with that? So
sure. We've
got a business here that's got 60 people. We've been wearing masks for 6 weeks. Will we be wearing masks in our businesses for the rest of the year?
Not if I had anything to say about it, but you know, we're working on that, and I'll touch on that in a moment too.
Okay.
Yeah.
Other questions, Shay?
Okay, we have another question regarding what may be false attributions of death due to COVID-19, such as other comorbidities, other causes, and how that raised the numbers above, and what, you know, are these numbers really accurate? And I will add to the question, I know that I've heard at least one or two doctors say that, claim that they've heard that other doctors were being pressured to add COVID-19 into the cause of death. So.
Yeah, I don't want to dive too deeply in that, but what I'll say is that I think it's gone both ways, that extra cases have been lumped into deaths by COVID when it was just deaths in the presence of COVID. Okay, I think we have probably a lot of those, but I can't tell you how many. I think it also goes the other way too. I think there's been a lot of deaths by COVID that never were tested. Have they been added now subsequently as probables? Possibly.
Yes, we've got about 7% of the deaths reported in the state of Ohio were probable, so we definitely have some of those in the data set. So this is something that I think is going to clear itself up over time, right? So what we're actually seeing reported, like the big headline numbers that are in the state of Ohio at the United States level, okay, are just total deaths. They don't give you any distinction between dying of COVID-19 or dying with COVID-19. However, when we actually get to the death certificate that gets reported, so the CDC is actually tracking that as two separate codes. Unfortunately, the reporting mechanisms that get to the CDC have about a 3 to 4 week lag before we start to see realistic numbers on that. So you're seeing right now that, again, you know, most cases are still death of COVID-19 that are being reported. Probably about 2/3 of those, 1/3 are shown as with COVID-19. And there is definitely a financial incentive for institutions to go through and report them as COVID-19 deaths. Now, I think, again, you know, the medical profession, there's, you know, I think a lot of integrity in there to try to do the right thing. But at the same time, let's understand that, you know, because we kept people out of the hospitals were furloughing personnel because their budgets took such a hit. During a pandemic, they were having people stay home, right, because of that. And so, again, to the extent that they're getting extra reimbursement for COVID-19, they have a pretty powerful financial incentive to try to make sure as many cases as possible, you know, subject to ethical limitations, get reported that way.
Mike Wilson, can I ask you a question? With only 600 people in the hospital and there being 34,000 hospital beds in Ohio, what was the reason that hospitals weren't open a month and a half or 2 months ago?
I'm not sure I have a good answer for you because I can't justify it from the data. Right. I mean, we heard over and over through the course of April that there was a surge that was going to, you know, coming to pass. Right. They kept predicting we're going to see this surge. We don't know when it's going to come, but we know it's going to come. And again, the data said at the time that surge was not coming. Right. We knew that we were pretty much at the top of the curve and it was going to stay flat. Right. But at the same time, we also didn't know how quickly we were going to go down the backside. And I think there was an abundance of caution, far too much caution, obviously, in retrospect, and going through to continue to delay that. Because the other side that we didn't talk about today is just the cost of this, right? I mean, so we know the benefits that some of the social distancing did have an impact, but I think it was more individuals versus government induced. But again, you know, the people that delayed medical procedures, that didn't go to the hospital for serious issues because they were afraid of COVID-19, you know, all of that stuff ends up causing deaths too.
Thank you. Does anybody in the audience has a question? Please raise your hand. We'd love to take your question too. I think we have a couple more online. Jay.
Hey, Dan.
Yes.
Can I think the next slide is really
Let
important.
me hit a couple more things.
Okay,
Yeah.
go for it.
Okay,
So we'll come back to a couple questions.
Yeah, real quickly, I just want to touch on the 6-foot rule. Just so you know, this is not magic, okay? It was invented in the 1930s with one study that was done looking at respiratory droplets coming out of people's mouths while they sat there and breathed normally and talked, okay? No yelling, no singing, you know, no coughing, no sneezing. It's been debunked by other studies many times since the 1930s. Yet in 2006, the Bush pandemic working group decided to adopt that without reduplicating studies or repeating studies as the gold standard. And a year later, the CDC said, okay, well, if they're doing it, we're doing it. So that's why we're all sitting at 6 feet right now. We know well that 6 feet does absolutely nothing. The CDC actually recently said, and the WHO did within the last 2 weeks, that, oh, this doesn't work. Actually, it probably should be 12 feet. Why is it 12 feet? Why? 6 times 2 is 12. All right, so that's who's leading us right now. All right, so just know the 6 feet rule is it's a myth. It's an absolute myth. And I do want to mention one more thing, and that is, you know, how are we coexisting with this virus? We talked about herd immunity. You've heard this in the press. You either have a vaccine, you have herd immunity. They tell us we can't get herd immunity. We have to have 80 to 90% of people infected. That's not true. There's something called a herd immunity threshold. It sometimes requires only more than 7%, maybe up to 20% of people to have gotten infected and have positive antibodies before we can coexist with the virus by slowing it down. And that's probably why right now, despite the fact we're trying to get infected in this community, right? We're marching in protests, we're rioting, we're reopening, we aren't mask wearing, we're not social distancing as much, we're at the restaurants. We're trying to, but we can't, and the numbers are still going down. And that's because we probably have already reached this herd immunity threshold. We're at least at 7%, we could be higher. And lastly, I just want to summarize this. Knowing what we know from the numbers standpoint and what I've given you from what the scientific basis is for why we're doing what we're doing, is there any support to have any further closures based on a health standpoint? The answer is absolutely not. What Mike has just said is true. We know that the health impact, and this has been repeated, actually since 2006, people have been protesting this. Virologists have been protesting it, saying that this white paper, the CDC recommendation that was adopted, 6-foot rule, blanket closures, long-term lockdowns of businesses and schools were proposed by this Bush pandemic group in 2006 and by the CDC in 2007. We know now that the negative impact, and this was declared by people that had rebuttals to it back then, that the negative impact was going to be much greater than any positive impact that it would have. And long-term closures of schools, long-term closures of business, cause alcoholism, opioid abuse, child abuse, domestic violence, suicide, missed vaccinations, missed cancer screenings, and very importantly, people with mild chest pain aren't going to the hospital. My wife's a cardiologist. I know we had at least a couple of her patients, she said, who didn't come in, and I know a couple of the patients at the VA died because they stayed home because they were afraid to come to the hospital because of the fear-mongering that was going on in the press. So it's very important to note that the negative impact has been tremendous. Economically, this is my opinion, there is no scientific evidence to support long-term lockdowns of schools or businesses any time in a pandemic, and that was supported by very strong rebuttals in 2006 before the CDC adopted this approach, which, by the way, was never implemented ever, even though it was adopted in 2007 until this year, 2020 with COVID-19. It wasn't used with the prior pandemics between now and then. But there is absolutely no scientific evidence that suggests there should be any continued business closures in Ohio, and there shouldn't be any mandated social distancing in Ohio, because that's a made-up number too, okay? We as humans want to live, we do. We adapt. We know we don't want to get right in somebody's face. We want to respect personal space, you know? That's social distancing, and we do that on our own. We don't need a government order to tell us to do it. And the data that Mike presented shows that actually the growth curve changed on that virus when we decided to do it on our own, a full week before any government orders came in. And lastly, mass gatherings in Ohio. As of this point, I see absolutely no reason why outdoor mass gatherings, whether it's spectator sports, outdoor concert venues, and to be honest with you, I don't see any reason at this point in time, based on where we are in this curve, that indoor mass gatherings such as church, funerals, weddings, wedding receptions, sports venues, concert venues should not be open. There should be no government orders against this. Those of us who can assess our risk and say, hey, I'm not one of the vulnerable, I feel comfortable going. If there's enough of us, that business can survive. If we don't believe that, and that should be up to us, then those businesses will no longer exist. And finally, and I believe this to be extremely important, I want all of you to get active in this over the next couple of weeks, even if none of you have any kids or grandkids in school. If you have them in public school in Ohio, Governor DeWine has stated that his plan right now, as it is today, is to send kids in public schools to school 2 days a week in the classroom, 2 days a week online while the other half comes in with 50% reduction, social distancing, and mask wearing by all the students. That's the plan right now. They've been sending out surveys to parents and to superintendents, but there is no scientific justification for any of this, okay? And based on science, if we're gonna go by science, public schools need to be open to full capacity, full classrooms, no social distancing, no mask wearing. This is not a disease of kids, and kids are not asymptomatic carriers who infect adults. Thank you.
Jay, let's take a couple more questions real quick. Anybody in the audience have a question? Jay, go ahead.
I think he just answered most of the, let me just double check here real quickly.
And we've got a question while you're checking that, Jay. Let's take one over here. Would you say your first name, please?
My name's Jimmy. And what was the change in the medical community from Europe to US regarding like steroids and high pressure ventilation?
Yeah. So what is the difference you mean between the European outlook on that? You know, actually, in terms of use of the anti-inflammatories, steroids, that actually was initially started in China, and then it was used in Europe, and then the American experience kicked in, and it's been a common experience. IV steroids, IV anti-inflammatories, as I said, like Actemra and a few others, is standard therapy now for the sick patients with lung disease.
Dr. Bulas, if you think that you may have been infected, you were sick in February, is it worth getting an antibody test?
You know, I thought I had it. Yeah, and another buddy of mine who's a physician in town, thought he had it too. We both had been traveling during that time. And we came back, we had a similar illness. And the difference was that for about 2-3 weeks, and the difference was he lost his sense of smell. I didn't. His antibodies were strongly positive, and he donated his plasma. I didn't have the loss of smell, and my antibodies were negative. Why is it important to get it? You really don't need it. It's really more for your own comfort of mind. You know, if you know you're strongly positive antibodies, you could help somebody else by donating plasma. You also may feel a little more comfortable that you have immunity.
Where would you go to? Do you have to get a doctor's prescription?
Oh, no. As a matter of fact, I went the first couple of weeks it was offered, and literally it took me 4 minutes. I drove through the back parking lot behind a internal medicine doc's office in Marymount area. And in 4 minutes, they done my finger stick, and 30 minutes later, they sent me an email and said I was negative.
Really?
So it was about a $40 charge. In retrospect, the only reason why I did is I wanted to donate my plasma. You know, I wanted to help.
Let's take a question right here.
Jerry here.
Hi.
You know, as far as testing goes, you know, how really valid is it, and how accurate are they? And when you say there's COVID within the blood, could that be any corona? And how do you identify it as COVID versus something?
In terms of the tests, neither one has extremely high sensitivity or specificity. So there's false positives and false negatives, both for the antibody test, and there's some false positives and false negatives for the virus test too, you know, the nasal swab, okay? Yeah, that's important. We're missing things, and we're overcalling some things, but we're not talking about 50-50. We may be talking about 85-15, you know, 85% accurate, 80% accurate, 90% accurate for some of them. So no, it's not, and there is some cross-reactivity probably. Maybe some people are not catching it or not getting sick from it because they may have had another coronavirus. There is a lot of speculation that that's true.
Yeah, what I've read on that, just to kind of add to that, so for the PCR test, the nasal swab aspect of that, so if you get a positive test, you almost certainly have it. There's been almost 0 cases where that's been incorrect. However, if you have a negative test, that's, you know, about a roughly 10% chance that that negative test wasn't accurate.
10%, that's a big.
Yeah.
One last question. We'll take 2 last questions, one in the back, Jay.
Okay, I've actually got 2 that I think can both be answered quickly.
All right.
Okay, Doctor, I know you briefly referred to this earlier, but I think there's still some confusion in the audience about the meaning of the terms COVID-2 versus COVID-19.
Okay. All right. Well, SARS-CoV-2 is the virus. That's the name of the virus. Okay. COVID-19 is the disease.
Okay.
That's it.
Okay. And then lastly, one person is asking about, you know, all of the dark possibilities that they're talking about in the media that this winter there's going to be another spike or a big second wave.
Yeah.
Thoughts?
Yeah. Both the recent stuff we've heard in the press the last few days saying how we're already having a spike in some states. We don't know that. A lot of us may because we're ramping up testing and more positive cases, but have not heard that there's been a big ramp up in hospitalizations, ICU bed utilization. In terms of a second wave in the fall, impossible to predict. It's just pure speculation.
One last question.
First of all, Dan, thank you for the online stuff that you've done over the summer and for getting this early start here on this. Thank you for the presentation. And I just wonder how anybody with just a little bit of statistical knowledge cannot be puzzled by the lack of information that went out there. Thank you.
Yeah, I guess I'll take that one. I will admit to being puzzled too by that scenario. But what I will tell you here is that the media, obviously, this isn't their area of expertise. Those guys obviously weren't math majors, right? So to some extent, I don't hold it against them, right? I mean, I wish they could go through and bring in, if anybody's out there, I would be happy to be a consultant to help them ask better questions. But in the end, right, I don't fault them. What I fault as part of this is ultimately Amy Acton in her role as the former director of the Ohio Department of Health. I expect her to have a solid handle on the progression of the disease in the state. And in the end, the fact that she didn't, for me, that again, it was one of those that she was either being deliberately deceptive or she didn't know. Both of those, in my view, were disqualifying to hold that position.
I'll make one more comment along the same thing, just in terms of what we're hearing, information gets out there. In 2006, when the CDC decided to make this our policy, lockdown is our policy in America for pandemics, there were papers written by two different people. One was saying that what we need in our leadership during pandemics is positivity, okay? Project positivity, not lying, but present accurate data and present positivity as a leader. Another paper came out the same year that said, when there's a pandemic, there's nothing wrong with using fear factor to get them to do what you need them to do, what you think they should do.
Well, I think,
so we'll leave it at that.
I think our example of tonight at EmpowerU is a good example of the fear factor, because we had 44 people sign up for the class tonight, which is what we limited it to. And almost always the number of people that come is exactly how many that signed up, a few plus, a few minus. And so we had 18 people come. We had a lot of people tonight make the decision right at the end that they didn't want to be out in public, which
Sure.
I understand. And we've got about 80 people online. So they all decided that they were scared. But what a great combination of the medical and the data. It was just a fascinating program. Let's give them a round of applause, everybody. Thank you so much.
Sure thing,
for coming in and spending all the time that you spent. And in terms of our winner tonight, on the book from Ben Shapiro, somebody who I haven't seen in a few years was online and won, and that's Mr. Tom Hoffman. So you'll be getting your book when it comes out in July, Tom, and I hope you're well. Other than that, thanks so much for coming tonight. Look forward to our 20th semester beginning in September. And who knows, if classes keep popping up, we may bring you back to summer school. Have a good night, everybody. Thanks for coming.